Shoulder calcific tendinitis is a condition characterized by the deposition of calcium hydroxyapatite crystals in the tendons of the rotator cuff, most commonly affecting the supraspinatus tendon. It is a common cause of shoulder pain, leading to significant morbidity and impairment of daily activities. This condition typically affects individuals between the ages of 30 and 60 years and is more prevalent in women than in men. Despite its high prevalence, the exact pathophysiology, risk factors, and optimal treatment strategies remain subjects of ongoing research. The precise etiology of calcific tendinitis remains unclear, but several theories have been proposed. It is widely accepted that the condition is not simply a degenerative process, but rather an active, cell-mediated phenomenon. The pathogenesis is divided into 3 distinct stages. The precalcific stage involves fibrocartilaginous transformation of the tendon without visible calcium deposits. The calcific stage is further subdivided into 3 phases. The formative phase, in which calcium crystals are deposited within the tendon, the resting phase, during which the deposits remain stable and may be asymptomatic, and the resorptive phase, where an inflammatory reaction occurs, leading to pain and the gradual breakdown of calcium deposits. The post-calcific stage involves the remodeling and healing of the tendon. As the calcium deposits are resorbed, the development of these deposits can be influenced by multiple factors, including local hypoxia, repetitive microtrauma, and metabolic imbalances. Certain systemic conditions, such as diabetes mellitus and thyroid dysfunction, have also been associated with an increased likelihood of calcium deposition. Although the exact mechanism remains unclear, the symptoms of shoulder calcific tendinitis vary widely. Depending on the stage of the disease, patients may be asymptomatic, or they may present with acute or chronic shoulder pain. The pain is often localized to the anterolateral aspect of the shoulder and can be severe, particularly in the resorptive phase. In many cases, the pain is exacerbated by movements such as abduction and overhead activities, making routine daily tasks challenging. Night pain is a significant complaint among patients, often interfering with sleep quality. Some individuals experience stiffness and restricted range of motion due to inflammation and discomfort. In more severe cases, muscle weakness may develop due to disuse and guarding behaviors, further impacting the patient's ability to perform overhead tasks or lifting movements. Diagnosis of calcific tendinitis is based on clinical presentation and imaging studies. Plain radiographs are the first line imaging modality and can demonstrate calcium deposits within the rotator cuff tendon. These deposits may appear as well-defined, homogeneous opacities or as irregular, fragmented collections. Depending on the disease stage, ultrasound is a valuable diagnostic tool that provides additional information regarding the size, shape, and consistency of the calcium deposits. Additionally, ultrasound can help identify associated bursitis, or tendon thickening. MRI, while not routinely required, may be useful in cases where there is suspicion of concurrent pathology, such as rotator cuff tears or degenerative changes in the shoulder joint. Laboratory tests are typically not necessary, but may be ordered to rule out systemic inflammatory conditions or infections in patients with atypical presentations. The management of shoulder calcific tendinitis is dependent on the severity of symptoms and the stage of disease progression. Initial treatment focuses on conservative measures aimed at reducing pain and improving function. Activity modification is often advised to prevent exacerbation of symptoms. Nonsteroidal anti-inflammatory drugs and NSAIDs, such as ibuprofen and naproxen, are commonly used to manage pain and inflammation. Physical therapy plays a crucial role in treatment, with specific exercises designed to maintain shoulder mobility, strengthen the rotator cuff, and improve overall function. Modalities such as ultrasound therapy and extracorporeal shock wave therapy, ESWT, have shown promising results in breaking down calcific deposits and promoting healing. Corticosteroid injections are another therapeutic option, particularly for patients experiencing severe pain or significant inflammation. These injections are often administered into the subacromial space or directly into the affected tendon to provide relief. For patients who do not respond to conservative measures, interventional procedures may be necessary. One of the most commonly performed procedures is ultrasound-guided needle aspiration and lavage, in which a needle is used to break up and aspirate calcium deposits. This is often combined with saline or local anesthetic injections to help dissolve residual deposits and reduce pain. Extracorporeal shock wave therapy is another non-invasive treatment that delivers high-energy sound waves to the affected area,
promoting resorption of calcium deposits and stimulating tissue healing.
This approach has been found to be particularly effective in patients with persistent symptoms and radiographically significant calcification. Surgical intervention is generally reserved for refractory cases where conservative and interventional treatments have failed. Arthroscopic calcium removal is a minimally invasive procedure that allows for direct visualization and debridement of the calcium deposits. This procedure is often combined with subacromial decompression to relieve impingement and enhance post-surgical recovery. In rare instances where calcific tendinitis is associated with extensive tendon degeneration or tearing, an open surgical approach may be required to perform a more thorough debridement and tendon repair. The prognosis for shoulder calcific tendinitis is generally favorable, with most patients experiencing resolution of symptoms, either spontaneously or with appropriate treatment. The resorptive phase, although painful, often leads to complete dissolution of the calcium deposits, restoring normal tendon function. However, some individuals may experience recurrent episodes or persistent discomfort, necessitating long-term management strategies, such as regular physiotherapy and lifestyle modifications. Early diagnosis and intervention are crucial in preventing chronic complications and optimizing functional recovery. Shoulder calcific tendinitis is a common yet complex musculoskeletal disorder that significantly impacts patients' quality of life. While its exact cause remains uncertain, advances in diagnostic imaging and treatment modalities have improved the understanding and management of this condition. A structured approach that begins with conservative therapy and progresses to interventional or surgical options as needed provides the best clinical outcomes. Ongoing research into the underlying mechanisms and optimal therapeutic interventions will continue to enhance our ability to effectively treat this painful and often debilitating condition.